Nobody warned Margaret. That is the part that still stays with me. She was 71 years old, sharp as a tack, still driving herself to her grandchildren's school plays, still tending her garden every Saturday morning. She took her medications exactly as prescribed. Every pill, every day, every time. She did everything right. And then one morning her daughter found her on the kitchen floor, confused, her heart hammering at a rate that should not be possible in a living person, her blood pressure so low the paramedics could barely get a reading. Margaret had not made a mistake. She had simply combined 5 medications that her 3 different doctors had each prescribed without any of them knowing what the others were giving her. She spent 11 days in the intensive care unit. She lost 6 months of her life to recovery. And when she finally asked her cardiologist why nobody told her this could happen, he had no good answer. That question has stayed with me, because Margaret is not an exception. Margaret is happening in homes across this country every single day. Here is what nobody tells you. The danger is not always in a single wrong medication. Sometimes the danger lives in the combination, in the space between 2 pills that each seem harmless on their own, in the interaction that forms when chemistry meets chemistry inside an aging body that no longer processes drugs the way it did at 40. If you or someone you love is over 60 and taking more than 2 medications, you need to watch this entire video. Because what you are about to learn may be the most important medical information you have never been given. Stay with me. The surgeon speaking to you today spent more than 3 decades inside operating rooms, over 2,000 cardiac surgeries. I have held beating hearts in my hands. I have watched what happens when the body is pushed past the edge of what it can tolerate. And I can tell you with absolute certainty that some of the most preventable crises I have seen on that table began not in the operating room, but at a kitchen counter with a pill organizer and a glass of water. I spent years watching patients arrive in critical condition from drug combinations that should never have been allowed to coexist inside a single human body. I watched the system fail them. Doctors who were not talking to each other, pharmacists who filled prescriptions without access to a patient's full medication list, a healthcare infrastructure that treats each prescription as an isolated transaction rather than one piece of a complex chemical equation. I decided I was not going to stay silent about it. Here is something most people do not understand until it is too late. The body at 65 is not the body at 45. The kidneys that once filtered medications efficiently now work at perhaps 60% of their earlier capacity. The liver that metabolized drugs quickly now takes longer, sometimes much longer, allowing compounds to build up in the bloodstream at concentrations that were never intended. Fat-to-muscle ratios have shifted, changing the way fat-soluble medications distribute themselves through your tissues. And the digestive system moves more slowly, meaning pills that were designed to release at a predictable rate now linger longer than the drug's designer ever modeled. A landmark study published in the Journal of the American Geriatric Society found that adults over 65 are hospitalized for adverse drug reactions at a rate nearly 7 times higher than younger adults. 7 times. Not because they are careless, because their bodies process chemistry differently, and the medications prescribed to them were largely tested on younger populations. You are, in a very real sense, operating a sophisticated machine that has been running without interruption for 6 or 7 decades. And some combinations of chemicals will push that machine past its limits. Write that down. Now, the 5 medication combinations that should never exist together in a senior body. And I'm going to tell you not just what they are, but exactly what they do inside you and exactly what you need to do about each one. The first combination that must be discussed is blood thinners paired with common anti-inflammatory pain relievers. Warfarin and aspirin. Warfarin and ibuprofen. Warfarin and naproxen sodium. This combination is extraordinarily common in seniors, and it is extraordinarily dangerous. Here is why it happens. A cardiologist prescribes warfarin to prevent stroke or manage atrial fibrillation. The patient's knee begins to ache, as knees tend to do after decades of use. The patient reaches for the ibuprofen that has been in the cabinet for years, or perhaps a different doctor prescribes naproxen for arthritis without knowing about the warfarin. 2 medications. 2 separate, legitimate medical reasons, and a potentially catastrophic result. The mechanism is not complicated once you understand it. Warfarin works by suppressing the clotting factors in your blood. It thins the blood deliberately, preventing dangerous clots from forming. NSAIDs, the family of drugs that includes ibuprofen and naproxen, do something different. They thin the blood through a separate pathway by inhibiting platelets, the tiny cell fragments responsible for initiating clot formation. They also irritate the lining of the stomach and the intestine. When you take both simultaneously, You have doubled your anticoagulant effect through two different mechanisms, while simultaneously creating fragile tissue in the gastrointestinal tract that is now poorly positioned to stop any bleeding that begins. The result in older adults can be internal bleeding so severe that patients arrive presenting with symptoms that look like a stroke or a sudden cardiovascular collapse. The age risk compounds this. Older kidneys clear warfarin more slowly, meaning blood levels run higher than intended. The stomach lining in seniors is already more vulnerable. A combination that might produce minor bruising in a 40-year-old can produce life-threatening hemorrhage in a 75-year-old. Think about Robert. 68 years old, managed his atrial fibrillation responsibly for 4 years, never missed a warfarin dose. Threw his back out one afternoon and took 4 ibuprofen over 2 days before his wife convinced him to call the doctor. By the time he arrived at the emergency room, he had a significant gastrointestinal bleed that required hospitalization and transfusion. 4 ibuprofen. 2 days. That is all it took. If you are on any blood thinner, write this down. Do not take ibuprofen, naproxen, or aspirin without direct consultation with the physician managing your anticoagulation. If you need pain relief, ask your doctor about acetaminophen, which does not carry the same anticoagulant interaction, though it carries its own considerations at high doses. Starting tonight, check every over-the-counter product in your home. Cold medicines, sleep aids, and headache tablets often contain hidden NSAIDs. The label matters. Read it. Now, the second combination causing silent damage in seniors across this country is ACE inhibitors combined with potassium-sparing diuretics. And this one is particularly insidious because neither medication sounds dangerous. ACE inhibitors, drugs like lisinopril, enalapril, and ramipril, are cornerstones of blood pressure management and heart failure treatment. Potassium-sparing diuretics, drugs like spironolactone, help the body shed excess fluid while holding on to potassium. Both are prescribed with good intentions. Both are genuinely useful medications. Together, they can drive potassium levels in the blood to dangerously high concentrations, a condition called hyperkalemia, and hyperkalemia in the elderly is not a slow, gradual problem. It is a cardiac emergency. The mechanism begins with the kidneys. ACE inhibitors reduce the production of a hormone called aldosterone. One of aldosterone's jobs is to help the kidneys excrete potassium. When you block aldosterone, potassium tends to accumulate. Potassium-sparing diuretics work partly through the same pathway, also blocking aldosterone's effect. Stack both medications together, and the potassium retention effect is additive or worse. In older kidneys that are already clearing minerals less efficiently, potassium can rise to levels that disrupt the electrical system of the heart. Cardiac arrhythmia, sometimes fatal. The particularly deceptive element of hyperkalemia is that it often has no obvious symptoms until it is critical. Mild cases may produce muscle weakness, fatigue, or a vague sensation of heaviness. These are symptoms that many seniors attribute to getting older, not to a drug interaction. So the warning goes unheeded. The potassium continues to rise, and the heart begins to receive confusing electrical signals. If you are taking both of these medication types, this is not a reason to stop either without guidance. It is a reason to call your doctor today and ask when your last potassium blood level was checked. Monitoring is the specific fix. Regular blood work, at least every 3 to 6 months, can catch a rising potassium level before it reaches the danger zone. Your doctor should already be doing this. If they are not, ask. Starting tonight, write down every medication you take, including the drug class, and bring that list to your next appointment with the explicit question about potassium monitoring. Stay with me, because the next combination is one that most people have never even considered as a risk. The third combination, and this one has ended careers, ended lives, and destroyed families who had no idea what was happening until far too late, is central nervous system depressants combined with other central nervous system depressants. Specifically, benzodiazepines combined with opioid pain medications, sleep aids, or certain antihistamines. The sleeping pill your doctor prescribed, the anxiety medication you have taken for years, the pain medication from your orthopedic surgeon after your hip replacement, the antihistamine in your nighttime cold medicine. Each of these compounds acts on the central nervous system. Each of them, alone, carries a degree of risk that is manageable in a healthy younger adult. In a senior body, combined, they can suppress the respiratory drive below the threshold required to maintain consciousness and breathing. Falls become catastrophic because coordination and reaction time collapse simultaneously. In 2016, the FDA issued its strongest safety warning about combining opioids with benzodiazepines, citing thousands of deaths. Research published in the British Medical Journal found that seniors taking this combination faced a dramatically elevated risk of hip fracture from falls, often at night, going to the bathroom in a darkened room with a nervous system operating at a fraction of its intended alertness. The specific fix here is a medication review with your primary care physician that explicitly addresses every sedating medication in your cabinet, including over-the-counter products. Many antihistamines, including common allergy and sleep aids, carry sedating properties that interact with prescription medications in ways patients are never warned about. Write down every substance you take to sleep, every substance you take for anxiety, and every substance prescribed for pain, and place that complete list in front of your doctor at your next visit. Ask the direct question, is any combination on this list dangerous for someone my age? Your doctor may not volunteer this conversation. You must initiate it. The fourth combination sits in the medicine cabinets of millions of seniors, overlooked because both medications have been taken for years without obvious incident. It is the combination of certain antidepressants, specifically selective serotonin reuptake inhibitors, with tramadol, a pain medication frequently prescribed in older adults for moderate to severe pain. SSRIs, drugs like sertraline, fluoxetine, and escitalopram, work by increasing serotonin availability in the brain. Tramadol, in addition to its opioid-like pain-relieving mechanism, also inhibits serotonin reuptake through a separate pathway. When both are present simultaneously, serotonin levels can rise to dangerously high levels in a syndrome called serotonin syndrome. And serotonin syndrome in elderly patients is frequently misdiagnosed as a psychiatric emergency, a stroke, or simply as delirium from another cause, because the symptoms, agitation, confusion, rapid heart rate, elevated blood pressure, abnormal reflexes, and in severe cases, high fever and seizures, do not announce themselves with a label. A 73-year-old woman named Elaine spent 4 days in a neurological unit being evaluated for a possible stroke before a young pharmacist, reviewing her medication list for an unrelated reason, identified the combination and flagged it. Within 36 hours of stopping the tramadol, her symptoms began to resolve. 4 days of intensive testing, a potential stroke workup. The answer was 2 medications in the same cabinet that should never have been there together. The specific fix here is to ask your doctor every time a new pain medication is being considered, whether you are currently taking any antidepressant. SSRIs and SNRIs, a related class, both carry this risk with tramadol. If your pain requires management and you are on one of these medications, alternatives exist. The conversation simply must happen. Write down the name and class of your antidepressant. Carry it with you. Hand it to every prescribing physician you see. The fifth combination is one that affects the most fundamental systems in the aging body and is responsible for a pattern of quiet, progressive deterioration that is misattributed to aging itself far more often than it is correctly identified as a drug interaction. It is the combination of certain antibiotics, particularly fluoroquinolones, such as ciprofloxacin or levofloxacin, with antacids or supplements containing magnesium, aluminum, calcium, or iron. Here is what nobody tells you about this one. The interaction does not produce a dramatic emergency. It produces a quiet failure. When fluoroquinolone antibiotics bind to minerals in the gastrointestinal tract, they form an insoluble complex that prevents the antibiotic from being absorbed into the bloodstream. The antibiotic that was prescribed to treat a urinary tract infection, a respiratory infection, or a skin infection simply does not reach the bloodstream in adequate concentrations. The infection does not clear. The patient is told the antibiotic is not working. A stronger antibiotic is prescribed, or the infection worsens, or the bacteria, exposed to subtherapeutic antibiotic levels, develop resistance. All because nobody mentioned that the calcium supplement taken every morning with breakfast should not be taken within 4 hours of the fluoroquinolone antibiotic prescribed at the same appointment. The age risk here is compounded by the fact that seniors are more frequently prescribed both antibiotics for infections that are harder to clear and mineral supplements for bone health, making this combination extraordinarily common in the exact population where it is most likely to occur and least likely to be monitored. The fix is specific and actionable starting tonight. If you are prescribed any antibiotic, ask your pharmacist directly, are there any supplements, vitamins, minerals, or antacids I should not take while on this medication, and how many hours apart should I separate them? Write down the answer. Do not assume the prescription instructions cover this. Frequently, they do not. I want to tell you something. I have never told a patient from behind a surgical mask. There is a moment in every procedure, in the silence before the first incision, where I think about the people waiting outside those operating room doors. Spouses in uncomfortable chairs. Adult children watching the clock. Grandchildren who were not told exactly how serious things were because there was no need to frighten them. And in those moments I have thought more than once, if this patient had known, if someone had simply told them this one thing, would they be here at all? The families waiting in those rooms never asked for anything extraordinary. They asked for ordinary time, Saturday mornings in a garden, school plays and birthday dinners, Ordinary time, lost to combinations that were entirely preventable. Some of the most serious cardiac events I have witnessed in my career were not caused by a damaged heart. They were caused by a medicine cabinet that nobody had reviewed in years. I want to tell you about Thomas, 74 years old when I met him. Retired mechanical engineer, methodical in the way that engineers tend to be, a man who kept meticulous records of his medications in a notebook going back 8 years. He came to me, not in crisis, but because his primary care physician had finally done something that should have happened years earlier. She sat down with that notebook and reviewed every medication against every other medication, taking 40 minutes that are not reimbursed at the standard primary care rate, and identified 2 of the interactions I have described to you today. Thomas's blood pressure medications were adjusted, his pain management was restructured, and the potassium monitoring that had been inconsistent for 2 years was placed on a regular schedule. 6 months later, Thomas described feeling, in his words, like someone had turned the lights back on. He had attributed the fog, the fatigue, the heaviness to age. It was not age, it was chemistry. He went from 4 medications to 2 in the categories that posed the highest interaction risk. And he told me at his follow-up that he wished someone had asked these questions 10 years earlier. That question has stayed with me. Let me bring this together for you. 5 medication combinations that every senior and every family member of a senior needs to understand. First, blood thinners such as warfarin combined with NSAIDs including ibuprofen and naproxen. The risk is serious internal bleeding that can present as neurological collapse. Second, ACE inhibitors combined with potassium-sparing diuretics. The risk is hyperkalemia, a dangerous rise in blood potassium that disrupts the electrical system of the heart without obvious warning symptoms. Third, benzodiazepines or sedating sleep and anxiety medications combined with opioid pain relievers or sedating antihistamines. The risk is profound central nervous system depression, dangerous falls, and in severe cases, respiratory suppression. Fourth, SSRI antidepressants combined with tramadol. The risk is serotonin syndrome, frequently misidentified as a stroke or psychiatric emergency in elderly patients. Fifth, fluoroquinolone antibiotics combined with mineral supplements or antacids. The risk is antibiotic treatment failure, disease progression, and antibiotic resistance from inadequate drug absorption. Here is your specific action starting tonight. Write down every medication you take, including the drug class. Write down every supplement, vitamin, mineral, and over-the-counter product. Bring that complete list to your next medical appointment. Ask your doctor or pharmacist to review it for interactions. Ask when your kidney function and your blood potassium were last checked. Ask whether any sedating medications overlap on that list. Ask about timing restrictions on your antibiotics relative to your supplements. You are not being difficult by asking these questions. You are doing exactly what a person who wants to live fully should do. If this information helped you today, share it with one person you love who is over 60 and takes more than 2 medications. You do not need to explain the pharmacology. Simply say, "Watch this." A single conversation started by this video could change the outcome for someone you love. Subscribe if you want more of what the medical system rarely takes the time to explain. Because your heart has been working for you every single minute of every day of your life without asking for anything in return. It deserves for you to know the truth. A word before you go. Everything discussed in this video is based on published medical research and clinical experience and is intended to educate and inform, not to replace your relationship with your own physician. Do not stop or change any medication without first consulting your doctor. Individual medical situations vary in ways that no video can fully account for. What this video can do is give you the knowledge to ask better questions. It is never too late to ask better questions. Start tomorrow morning.